V shape. Sometimes they can mask themselves in other ways, but I won't give you any of those. Again, I'm serious. I have a book at home that's about this thick, and it's full of strips. And I can't read most of them, to tell you the truth. Even when they tell me what it is, I'm trying to search and find it. It's like looking at an MRI or something without being trained, you know? So we're going to see things that look like this without the red dotted line, okay? But it's still the same concept. The variable part here comes as the time. So variables can come anywhere, early or late. They come in between contractions. Doesn't matter. They vary in the time. Earlies are early, lates are late. Variables vary in the time, and they're V-shaped. And they're caused by what? Cord compression. Okay, so here are some lovely V's. Now, if you look at the fetal heart part, you can see the V's for the variables. These may not be as concerning, and we may not do something, because look at the contractions on the bottom. You see those big plateaus? Does anybody know what the plateaus are? She's pushing. That's usually what the EFM will look like when they're pushing. They get these plateaus kind of flat across the top during that time. So if you have a variable during pushing, meaning delivery is probably fairly soon, you may not be as concerned, because you'd almost expect it. Because now, if they're about to deliver, that cord is already stretched the maximum amount that we were given, you know, at the creation of time. I'm not sure I said that right. Okay. Questions about any of that? We already talked about that. I'm not going to say it again. Okay. So, our job, certainly we can't stop these types of deceleration, but we can note them and we can report them, and that's our most important role. And a couple of things, just FYI, regardless of where you work in nursing, you're reporting adverse signs, symptoms, events, etc. to a healthcare provider, and you're paging them, and they do not return your call. What do? Say, what a jerk, they never return my call in the middle of the night, and throw it up and badmouth them? Is that the end of your responsibility? No. What do you have to do?
Charge nurse know, let correct house officer know.
Depending on where you are, you'll follow the protocol, but you follow the chain of command. So if you're the charge nurse already, then you're probably going to report that to the supervisor of your shift or your nurse manager, but you go on and up, and then they will help you. You are never alone. I have a friend who does expert testimony for nurses who are being sued, and she said that's the biggest cause, is nurses fail to follow the chain of command. They saw it, they did it, they documented it, but they didn't tell anybody. Or they told somebody but didn't get a response. And even if you tell somebody and you don't get the correct response, if you use your SBAR and you tell them what you think is happening and what you want, and they say, but Sasha, you know, I know you haven't been a nurse very long, you've been a doctor for a long time, and I'm telling you this is okay, and I'll see him in the morning. Click. Is that the end of it?
No.
If you think that's not the end of it, don't let it be the end of it. Because we are, if you read the Facebook memes, we are the only thing between the patient and the healthcare provider.
We're their advocate.
Right?
We are their advocate.
We are their advocate, yes, for keeping them safe, okay? So that's really easy for me to say as an old person and an old nurse, not easy for you young people or you young nurses. That's why you use the people you work with. That's why you get them to help you make the decision, should I continue on with this? That's why hopefully you're not on the night shift with all people you graduated with. It'd be fun like old home week, but none of you know anything yet. So hopefully you're going to work with somebody who knows something. And I know you're LPNs to RNs, but still it's going to be a little bit of a different role for you. So there'll be a growth and a transition period for you. It might just be a little different than for the basic student. So in 2008, the National Institute of Child Health and Human Development said, you know what? There's so many cases when the nurse in labor and delivery sees something and tells the doctor, oh, everything looks pretty good, or, you know, I'm just not liking what I'm seeing on this baby thing. My strip looks crappy. My strip is giving me a little bit of headache. Like, I'm thinking I want to check out and go home early. This strip is bothering me so much. Well, that doesn't tell the healthcare provider any information that they can use to make an intelligent decision. So the rule now, the standard of practice now, is to use these categories, category 1, 2, or 3. Category 1 is simple. So if I say to a healthcare provider, I got a patient here and they got a category 1 EFM strip. What do they know? They know they have accelerations. They may have early decelerations, but they don't have variables and they don't have late decelerations. They have variability, they have the right baseline. Everything there that's good, nothing's there that's bad. So if I say category 1, it means all that, and that's all I have to say. I literally talked to somebody once, no kidding, on the phone, who was on a boat in the Bahamas, scuba diving. Why this person was still taking call, I don't know. It was kind of hard to communicate, cutting in and out, a lot of noise, the motor, it was just terrible. So if I need to say every one of those things, boy, could that be missed. But just say category 1 would be so easy. Or category 3 means you better get off of the boat or call your friend and tell them to get in here and do something. And category 2 is harder. But category 1 is absolutely everything good. Category 3 is pretty much everything bad, meaning no variability. Look, no variability. Recurrent lates, recurrent variables, or bradycardia, or a pattern we're not going to worry about. So that's all bad. Now the hard part is category 2 is kind of in the middle, I don't really know. And this is where they make enough money to have the boat to scuba dive in the Bahamas on a regular cold Saturday. Okay? Because that's what they get paid for. Because they're going to take that information and make a decision that's going to give us a good outcome for the mom and the baby that we're not going to take. And they're going to be paid for that responsibility. Okay? So I'm probably not going to ask you any details. I might ask you, hey, category 1, what are you going to do for your patient? Sure. Probably that's all I'm going to do, as far as this category 1, 2, and 3. You should have some knowledge of that, okay? Because it's not what I might do, it's what somebody else might do in the future. So here's what we call interventions for category 2 or 3. And it's really what I used to call, and still kind of do, intrauterine resuscitation. Because basically in category 2 and 3, we're having a fetus who's showing us some signs of distress. And so we need to resuscitate. But we can hardly get the AED out, right? So we're going to do things in 3 main categories. Identify the cause. But you know what? That's not the number 1, because I told you, we may never know the cause of it. We might know it after delivery. We might know it in 5 hours, 14 days. I don't know. But we can say, oh, we'd like to know. But that's not our focus. Our focus is resolving this problem. So we do that in 3 ways. And I suggest you try to remember them in these 3 main categories. And it kind of looks like, you know, the first, the stages of labor, and that the first one has some stuff under it. The other ones don't really have much under them. So increasing placental perfusion, that is a very general term. We want to get, this baby's fetus is in distress. We obviously think they're hypoxic or anoxic. We want to get them more oxygen. How can we do that? We can do that by positioning. What position would we put the mom in? Left lateral. What if she's already left lateral? Let's put her on the right lateral. What if she's already, or what if we do that and that doesn't work? Put her in the old-fashioned, well, if she's numbed up, you can put her in Trendelenburg. If she's not, you can put her in the knee-chest position, where the chest, so she's down like this, tail up, right? Trendelenburg, when you do that on the bed, what's up and what's down? Somebody told me a long time ago, I used to have trouble remembering it, but one of you, a student told me, it's trendy to be butt up. Sorry if that offends you, but I've never forgotten it since. It's trendy to be butt up. If your butt's up, that means your head's down. So maybe you won't ever forget it either. Okay? So yes, the beds can do that. So you put them that way. The reason is, if this is caused by compression of the cord, now we've turned them upside down, and maybe the fetus went towards their chest and is no longer compressing the cord at near the cervix. Okay? We give them fluids. Open them up. Give them lots of fluids because that can help. Tocolytic. Right now, today, I want you to remember that tocolytic is a medication that stops uterine contractions. That's what I want you to know. Man, people are just texting. on one string. Don't know why I'm on that, but okay. So a tocolytic is a medication that stops the uterus from contracting. Because in this case, we have a fetus who's in distress, and this contractions are making it worse. So we want to now relax the uterus. If she's in spontaneous labor, it doesn't matter. We're going to relax the uterus. If she was on Pitocin, we want to relax the uterus. So we'll give a tocolytic. Anybody know one on the top of your head? I'll let you. Terbutaline or breathine. Yes, and we'll talk more about that because we use it for preterm labor. So in this case, just know you want to give a tocolytic to stop the uterus from contracting. If they have Pitocin that's infusing, we will either decrease it or turn it off. Now, none of these on this whole page, position, fluids, tocolytic, decreased Pitocin, or anything that comes in the next two, do I have to call anybody and ask about? Because they're on my standard orders, my standard labor and birthing protocols. If this, category 2 or 3 events, then you may do this. That doesn't mean you're never going to notify the healthcare provider, because you are. Because even if, let's say you do all these things, voila, now we're back to the boom with accelerations, everything looks beautiful, we're like, that was a rough one, but everything's fine now, we're ready to take a break. And you don't notify the healthcare provider, and if it happens again, and if there's an adverse event, they will say, well, how did I know it wasn't the first time? Angie never called me. Angie's gonna call me. So they come in and they say, but didn't you see it on the strip when you came in 3 hours later? But there was an emergent situation then. I didn't have time to look back on 3 hours of larger strips. I just looked at then and went with it. Angie never told me. And there will be no documentation that Angie ever told me, because she did, or her. So I'm saying, you do all these things, and it's not a one-person thing. You're going to push the red button, you're going to push the light. Sometimes you don't have to do anything. In your all's emergency last week, did you have to push the red light, or did everybody who was seeing it on the monitor just come and help you?
Oh, well, the doctor was in the room, so
Okay.
it was just the nurse and then the anesthesiologist, because she had an epidural, and that was it, and me.
Oh, how exciting for you. So you eventually will document and notify, but you don't want to notify before you have at least one teeny little piece of information, right? So as the team comes together, somebody will be responsible for doing these different things. Somebody's going to position the patient. Somebody's going to turn up the fluid. Somebody's going to decrease the Pitocin if that's appropriate. Somebody's going to get a tocolytic ready and be ready to get it. Somebody's getting vital signs. Somebody is going to increase the blood oxygen saturation of the mother by doing what? By giving a non-rebreather mask at 10 liters. We don't mess around. Now, is it because the mother's O2 stat is low?
No.
No. It's the fetus who's low. But we've got to highly saturate her blood to get it to the fetus. So we don't mess around with little wee ways of giving oxygen. We go for the big gun. We're going to give you non-rebreather at 10 liters. Okay? And then reduced cord compression can be done either by positioning or putting your fingers in the vagina, if that's the problem, right? Through the vagina to the cervix to hold up the part. Okay? You're not going to put in an IUPC. That won't be your responsibility. But positioning, what kind of position would you expect if they have variable decelerations representing cord decompression? Yeah, probably Trendelenburg. You don't know if that's going to work. Because remember, it could be that it's just wrapped around the neck 3 times. It could be a triple nuchal cord. And every little fraction of a space they descend more into the pelvis, it just pulls tighter and tighter. But you're going to try to do that. Amnio infusion is only going to occur if the healthcare provider puts it in, or if it's already there, and then you can put the fluids in on this little doodad on the end. So, big things you're going to do to address category 2 and 3 are increase placental perfusion, increase maternal blood oxygen saturation in order to get to the fetus, and reduce cord compression. I don't know, only 1 hour to go. I don't know. We gotta just go faster. Second stage. Oh, I like this. What is a womb? Well, a womb is a room where a kid will be sitting. A womb is all squishy, all moist and magenta, and if there's a kid, then it's full of a placenta. But the kid must be small if there's one there at all, just the size of a bean or the size of a ball. When the kid gets too big, then it's time to get out. When it happens to you, you will probably shout. You will shout, you will yell, you will roll on the floor, because the kid must come out of a very small door. Isn't that cute? Kind of true. Yeah, I'm not going to show you this in the interest of time, but this is a person speeding to the hospital, and if you can see this picture at all, they deliver right outside the car in front of the ED door. And the funniest thing about this, I'll tell you, is she is a childbirth educator, and she screams the whole way, 2 minutes of the car ride. And the only way they got it is Dad's wearing a GoPro. So anyway, it's pretty funny. You can Google it and find it. So +4 station and delivery. So here you go. I told you 15 minutes ago she was at +3. Okay. So second stage is about the delivery. First stage is all about effacement, dilatation, assessing the patient's mother, fetus. Second stage is all about delivery of the fetus to a baby. Stages 1, 2, 3, and 4. The fetus will descend, engage, move down in station, and will flex. Flex what? Everything, but most importantly, the neck. Okay? 5 now, because those things all kind of happen at once. Descending, engaging, and flexing. They're all kind of all at one time. Because it says there are 8 things here, but I really think you can condense it more. And number 5 is internal rotation. So this fetus has to turn so that they are delivering in this position. In this position as they come out. So if they're over here, as they're descending and moving down, eventually now, they're going to have to turn around and get like this. So that they're facing the ground. Because that's the easiest way to deliver. They can deliver this way, and there's a slang for it. Does anybody know what the slang is? Sunny side up? Have you ever heard that before? Baby delivers sunny side up. The big thing about sunny side up, or a posterior baby, and see I didn't teach that, is that the mom has back labor. I'll just skip that. Never mind. Okay, so there's internal rotation, and then look at number 6. We've got like Tommy the turtle here. Now he's like, bring his head out of the shell, right? Yeah? And then external rotation. This is how the healthcare provider pulls them out. So they come out face down, but look, now they're turning. And you'll see your healthcare provider even kind of help them do that sometimes, okay? But now they have to turn to the side because that's where they're going to aspirate the mouth or the nose. And which one did you do first?
Mouth.
Mouth and then nose. And then, of course, that's called crowning, okay? And then they come out. So crowning means what? It means you can see the head, you can see the hair on the head, right? It means that they're completely dilated and effaced and they have descended and delivery is imminent. Okay, so if you call me at 4:20 and say I want to stay because of a delivery and I ask you, well, where is the patient? And you say, well, they're crowning, I'll probably stay with you late after clinical. If you tell me, well, they just started pushing, I'm going to say, well, let's go home. It could be a couple of hours of pushing followed by a cesarean and I'm not going to stay all night, you know, which seems mean, but some people push for a long, long time. Some of you, I think, Titi saw a patient the other day, just pushed a few times, even on first baby, and whoop, popped right out, but you never know. Okay, I won't show you this, but I will tell you pushing. As I mentioned the other day, we don't go hold your breath, push, 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 push anymore. We really want our patients to use that other pushing sound, because it's better, but also to change the position. Lay them flat on their back, put their legs up. They're pushing against gravity. These two women are using gravity to help them push, okay? Now, they can't really do that if they're all numbed up. So that's a disadvantage, of course. But here, you're really pushing, and I don't know if any of you have experienced yourself natural labor without medication, but most women, when you get to the point of needing to push, it's almost like you can't stop it. Because it's just like something that takes over your body and makes you go like that. You're like, okay, I think I need to push. I gotta push, I gotta push, I gotta push. It's just like, it just happens to you. You're just like, oh. It's natural. Not everybody feels that. And you're not gonna feel it if you have an epidural. But if you had a non-medicated birth, you're gonna feel the need to do that. And it usually feels kind of good, you know, it's like, so it feels good. But anyway. I think this is on YouTube. Put a note that if you're interested in cord clamping, but I'm not gonna show it to you here. Most of the hospitals around here now are doing delayed cord clamping. And there's a reason for it, because there is still a lot of blood in the cord after the delivery of the fetus. And so Penny Simpkin, who is a long time women's health advocate, she's a childbirth educator, Lamaze person, and she's a physical therapist. She's not a nurse, but she's written books. Oh, she's so famous. I've seen her a couple of times speak, and she was 100 then. I don't know how old. She was still alive and doing stuff. But anyway, this is a very interesting video of why cord clamping being delayed is okay and a good thing. Most big hospitals are doing it now. Some are still not doing it because the practitioners, healthcare providers are not following current recommendations. Third stage of labor is delivery of the placenta. So here's the placenta. The placenta, this is the beefy, meaty side. This is the part that comes off of mom, and that's called Dirty Duncan. It has nothing to do with anything. This is the fetal side, and it's all shiny and pretty, as you can see there on the top right, and that's called Shiny Schultz. One of them is going to come out first, because as it comes out of the vagina, it's either going to come out like this, or it's going to come out like this, and it doesn't matter, as long as it comes out. Okay. Do try to examine the placenta when you're in labor and birthing. See if you can touch it before they take it away. Feel how firm it is. Look at all the little things. Feel the cord, how big it is, how tight it is. You know, try to get in there and see if you can touch and feel with gloved hands of cord. I'll put that on tape, I guess. So this is the third stage for the mom. Obviously, there's some more things for the mom, but for right now, third stage is related to the delivery of the placenta in particular. It's not like we've ignored the fact that she's breathing and has a heartbeat or not, okay? It's just that our focus right this second is looking at this placenta. You want to see that the placenta is all intact, and the healthcare provider will do that. And some of them are really good at teaching, and they'll talk to you and show you, especially if you look interested and ask them, you know, are all the pieces there? Does it look like everything came out or whatever? Depends on what sort of relationship you built with them getting this together. For the baby, now we have a baby, no longer a fetus, we have a baby. We're going to do the APGAR, which you guys are familiar with. Yes. What's the score? How's the score? 1 to 10. We're going to do vital signs. We're going to look at the umbilical cord, and we have two what? Two arteries and one vein. You remember that by the acronym AVA. AVA, A-V-A, 2 arteries, 1 vein. Where does the oxygenated blood pass through? 2 arteries. Look how big it is, right? Okay. So here's the APGAR. We're going to do gestational age. Unless you're at one of our facilities, which we know they don't do it except on their preemies or NICU babies, because they don't use the information. Other facilities may do that. Physical assessment, so going over some of the things that you have prepared for your quiz today, and identification. This is where they'll put the ID bands on the mom and the baby, and then that extra ID band goes on who?
Dad.
Or whoever.
Or whoever's there, I guess.
Whoever she designates. This is where things get kind of interesting. Because who she chooses to put it on, if she's unmarried, let's say they don't have a good relationship, and her mother is like all over the place, her mother wants that band on. You better not put it on him. So sometimes can be dangerous. What does that band entitle them to? One thing, take the baby out of the room in the bassinet. That's it. In the room, mother's in charge, and anybody can hold the baby. When she gets home, anybody can do it. It only allows them to be in the hallway with the baby in the bassinet, or to take the baby back and forth from the nursery. You have to have an armband. Now that you know that, that's every facility. You must have an armband to have a baby outside the room. So if you see somebody wheeling a baby down the hall and they don't have an armband on, you're just the student, what are you gonna do?
Report it.
You're gonna politely, you're not gonna report it, you're gonna politely, I'm sorry to stop you, but in this hospital for baby security, we require that the person in the hallway have a band. Tell them the truth, okay? And I see you don't have a band. They might say, oh, it kept falling off, so I tucked it up, or it was too big, so I shoved it up here. Whatever it is, don't leave their side. If they say, well, we're down here, okay, let's take the baby back to the room together. Go with them. Okay, one baby a few years ago, actually might have been one of the ones that was just returned in Jacksonville. That's how they lost the baby. Somebody, a nurse, actually said, oh, you have an armband on. Oh, I know, I'll take her back to the room. Nurse said, okay. She went wackadoo crazy, okay, because that person went to the end of the hallway, went down the stairs. This was a few years ago, before we had all this security. But even still, you can still get it off, especially if you know anything, okay? So don't lose track of them. You go back to the room with them. It's your responsibility for baby security too. Even in 2017, there'll probably be 20 babies stolen from a hospital this year. We only hear about the really, really big ones, but they are seriously still on. I don't know why